right, let's go ahead and begin. Good evening, everybody, and welcome to another online lecture brought to you by the AMSSM Fellows Online Education Committee. I'll be your moderator tonight, Dr. Myro Lu. This national lecture is sponsored by the AMSSM Online Fellows Education Subcommittee, which is part of the AMSSM Education and Fellowship Committees. The purpose of these lectures are to serve as an adjunct and not a substitute to your individual program's educational programming, provide fellows with direct access to educational experiences with experienced AMSSM members, and at times invited guest experts. These lectures can also help assist in the CAQ exam preparation. As a reminder that if you haven't already, mute your devices, microphones, and turn off all your videos. And after the program, please complete the evaluation, which will be in the chat. There will be a link sent out by Annie Meyer in the chat box. And if you miss any of the prior lectures or want to rewatch them, you can find them on the AMSSM channel on the YouTube. And then as a reminder to tune into next week, August 24th, at the same time, where we're going to have another talk by Dr. Daphne Scott for Clearance for Sport. So again, tonight, it is my pleasure introducing Dr. A.J. Monseau. Dr. Monseau is a professor of emergency medicine and chief division of sports medicine at West Virginia University. Originally from West Virginia, Dr. Monseau received his medical degree and completed his EM residency training at West Virginia University School of Medicine. He then went on to complete fellowship training in primary care sports medicine at the University of Michigan School of Medicine. Afterwards, he returned to his alma mater upon completion of fellowship in 2011, and Dr. Monseau has served as the team physician for VWU men's basketball, and in 2016 was a team physician for USA Wrestling at the Olympic Games in Rio de Janeiro. So Dr. Monseau, thank you again for coming on tonight and providing this lecture, and I'll go ahead and pass the screen to you.
Thank you, Myra. That's a very kind introduction. As I share my screen here. Does that look good, Myra?
Yep, looks good.
Excellent. Well, again, thank you. I also want to thank the education and the fellowship committees, and specifically the Online Fellows Education Subcommittee for this opportunity. I'm going to talk. We're going to angle this talk more toward acute cervical spine injuries. I want this both to be educational for the CAQ preparation, but also I want it to be very practical as we head into football season, and time we know is a great risk for acute cervical spine injuries. So disclosures, I have no financial disclosures, and the views, of course, are expressed here on my own, do not reflect my employer. So there were a few prior talks that are similar, or at least on this kind of remote subject, and I just wanted to highlight those. In August 2020, Dr. Edward Laskowski from the Mayo Clinic talked on sports-related cervical spine injuries. In March 2022, Dr. Julian Bales, who actually recruited me back here to WVU after my fellowship while he was still here, talked on cervical spine injuries in athletes. And then just 2 weeks ago, Dr. Will Den spoke on sideline emergencies in the class athlete and talked briefly. So, I have the benefit of coming after and being able to watch each of these presentations, and you should too. They're all excellent. The Dr. Laskowski's was limited to only 30 minutes, so he gave more of a wave talks kind of lecture, but he gave some great additional anatomy. I think it's probably because of his PM&R background. So I would definitely highlight that for you when you're doing your studying. Dr. Bales, of course, is a neurosurgeon, well known, and did more of a surgically oriented lecture, but again, gave some great advice, and we'll highlight a little bit of that later on in my lecture. And then Dr. Den, another emergency physician, sports medicine physician that I worked with over the years, really did a great talk and touched briefly on a couple of things that we're going to try to expand on today. So I have the benefit, as I said, of coming after them, being able to try to fill in or expand on some things. And at the same time, I don't necessarily have to repeat them, because you can go and do all of these on the YouTube channel for AMSSM. So what this talk is going to be We're going to talk some higher level stuff, but we're also going to talk some basics. We're going to talk about the rapid assessment of an acute cervical spine injury, talk about the need for immobilization and when that might need to happen. We're going to talk about need for imaging and type of imaging, and then some basic knowledge of some pathology, specifically some fractures and stingers and some others. There'll be some jokes thrown in that may or may not be funny, just to warn you on that. What it's not, this is not about chronic neck pain. So if you were hoping for chronic neck pain, I'm sorry to disappoint you. It's not what I do. There will be one chronic condition that I'll touch on only because it's a bit of a trivia question that I like to quiz residents on and fellows, and I think it's kind of interesting. We will not be talking about neck OA. It will not be an extensive anatomy review, although you should do that for your CAQ. And it's not going to be about long-term follow-up necessarily, although we will talk a little bit about some follow-up and return to play. So as we are told that we should in today's medical education model, we're going to start with some cases, and then I'm going to circle back to these at the end as well. So this is to kind of set the framework for our talk. So the first is a 47-year-old male weightlifter who injured his lower posterior neck during a competition. He has midline tenderness, so a CT is ordered and shows a spinous process fracture of C7. He has no neuro signs or symptoms, and he has normal strength and sensation. He would like to return to his competition tomorrow to compete in the bench press. Will you permit him to compete? You can think about it in your head. I want you to commit to an answer, though. It's the other thing I push our residents and fellows on, which is I want you to commit. You got to commit to an answer at least, or else you won't learn as much. So, case number 2, 21-year-old male football player. He suffered an injury in the game where his right arm had tingling and burning pain and numbness in his forearm and hand after making a tackle. He's brought to see you by his athletic trainer because his symptoms lasted about an hour, which was much longer than his previous 2 episodes of this earlier in the season. So what's your advice going to be regarding return to play? Case number 3. You've been asked to help cover a local horse racing track for both crowd and participation medical issues, but not the horses, of course. A 39-year-old female jockey is thrown from her horse when it falls. She initially does not appear to be moving. When you get to her approximately 1 minute after the fall, she is oriented to person and place, but is repeatedly asking questions. She states she is not in pain and is adamant that she wants to ride in her next race, which is in about an hour. So what do you do first? And will you allow her to ride in her next race? Case number 4. 15-year-old female soccer player is hit by another player while trying to head a ball, which caused her to fall under her head awkwardly. She could not move her arms or legs for approximately 15 minutes, but has had a completely normal mental status since the fall. She has a normal CT of the head and C-spine in the emergency department. What additional tests are needed in the workup of this condition? And now case number 5. A 17-year-old male football player attempts to make a tackle, but drops his head into what is known as a spear tackling position. He lies motionless on the field in a prone position. You rush to his side. He's alert and talkative, but cannot move and cannot feel his arms or legs. He has normal breathing. What is your first step in stabilization? And then when removing the helmet and shoulder pads, in what order do you remove them? All right, so we've gotten through some questions. So hopefully you're thinking about those. And we're going to set the scene. Clearly, this is one of the scenes where these type of things happen. But for event coverage, it can be a very different scene than this. We can have a high school setting, a large crowd, small crowd, urban, suburban, rural field, even what we have in West Virginia, some very what I call ultra rural, which is where the local critical access hospital has a screen door instead of a functioning door. And we do have a few of those around the state. And remember, for this, you're going to be practicing pre-hospital medicine. So you have to put yourself in that mindset. When you're on the field, you need to be in that mindset. And it really comes down to a differentiation between sensitivity and specificity for me. When I'm working in the clinic, I'm more on the specificity side. People want to know what's wrong. Of course, I want to catch things, right? That's the sensitivity side. But at the same time, people want to know what it is, and I want to try to hone in on it and do the workup to complete that. But when you're doing event coverage, you're in the sensitivity business. And it's your job to make sure that any of those really bad things, you need to catch those. All right, so as I got started on this and I wanted to get ready to have some pictures, of course, I did what everybody does, and I Googled football player neck injury. And one of the top things I saw was a picture of this, which I thought was rather entertaining. If you're not aware, this is in 2019. This is Renato Augusto for Brazil. And this is him holding his neck after he bumped into that referee and then laid and pretended that he was incredibly injured. The same year, a serious injury happened to Devontae Bosby of the Broncos, who was paralyzed for approximately 30 minutes. In 2010, you may have heard of the case of Eric LeGrand for Rutgers, who has been paralyzed from this injury. And then probably one of the most dramatic is in 1997. This is Reggie Brown playing for the Detroit Lions. He was in his second year out of Texas A&M. He suffered a C1-2 displaced fracture. And Reggie, unfortunately, had the innervation to his diaphragm compromised and had to have CPR performed on the field. And miraculously, he walked out of the hospital about 20 days later. And as you can see from the picture here, and this is from 2017, Reggie is doing quite well. All right, so our player goes down on the field, and we need to do our immediate evaluation. Do we need to do CPR? We're going to check our ABCs. As Will talked about a couple weeks ago, we changed that now to CAB, circulation. Of course, we view as much more important. There's plenty of studies showing that hands-only CPR can improve outcomes. So we need to be first assessing airway and breathing and circulation, as we say with the ABCs or CAB. There's only been a few times that I run onto the field immediately after an injury. All of them were in this scenario. But the next question is, do we need to immobilize this person? And the first point to make here is that immobilization is not the correct term. So immobilization is not feasible for the type of instrument that we utilize for this. So what we should really call it is spinal motion restriction. And for the trauma community, that is the term used now, no longer using mobilization. So what is spinal motion restriction? What do we use? You've all seen this. We have a backboard, we've got spider straps, we've got some pads to hold the head, we've got a C-collar. Of course, there's somebody who's got them all going on. For somebody who's playing football, a helmet typically precludes a C-collar. If they're going to be boarded in this way, then you pad the helmet and just tape the helmet to the board. There are some other things you can use, though, besides a backboard. There's a scoop stretcher, which, of course, kind of envelops the person from each side. You can use vacuum splints. They make the giant one to use in this way. You can use an ambulance cot is fine. You can use this. What you'll find is around the country, there's a huge variability right now in what EMS crews are willing to do or what their protocols say. In our area here, they're still using backboard and C-collar and trying to do that to most people. We actually are trying to get them to do it less. In other parts of the country, it seems that EMS crews may not even carry a backboard at times, and they're very reluctant to put somebody on a backboard as their protocols are pushing them not to. Of course, the HIPAA compliant C-collar we want to stay away from. Make sure you're putting a C-collar on correctly when you put a C-collar on. And so as we talk about spinal motion restriction, Fisher and his group came out with a consensus statement, which was from the American College of Surgeons Committee on Trauma, the American College of Emergency Physicians, and the National Association of EMS Physicians. And they did a great job of really outlining these things. Talking about backboard, but you don't have to limit it to backboards. You can use the scoop stretcher, vacuum splint, even the ambulance cot can provide enough immobilization for most of these injuries. And our indications are important. So the acutely altered mental status, whether that be from trauma or from intoxication, midline, neck, or back pain or tenderness, any focal neurologic symptoms such as numbness or weakness, an anatomic deformity of the spine, or distracting circumstances or injury, which I think are important to list separately here. So long bone fractures, degloving, crush, large burn, emotional distress, communication barrier, anything that impairs a reliable examination. It's also important that they note that when you do spinal motion restriction, is that it should be of the entire spine. You cannot safely rule out non-contiguous injuries, and we'll bring that up again here in a little bit. But if you have a concern for the cervical spine, you're likely unable to rule out thoracic or lumbar injuries. They also point out that times of transfer are risky, so we really want to try to do everything at once on the field or in the field so that we minimize these transfer times. And then they also touch on the rules for children. So age alone should not be a factor dictating spinal motion restriction. And there are some high yield symptoms such as neck pain, torticollis, neurologic defect, altered mental status, agitation, etc., and high risk mechanism. And then they also remind us that we should be looking at the posture of the patient to see if their head is preventing a neutral alignment of their cervical spine and requiring padding under the shoulders. So we've already covered some of those high yield kind of symptoms. And so this is then kind of in a larger list. This is our red flag list. And again, you'll recognize many of these just from what we went over. So next is imaging needed. And in fact, this question can likely dictate whether you're going to practice spinal motion and restriction on this patient or not. So when we think about imaging, we typically talk about several different modalities: plain films, CT, MRI with diffusion weighted imaging, diffusion tensor imaging, and Flex X film. But of course, the big thing we've all been schooled on recently in the last 10 years or so with all the Choosing Wisely campaigns is that CT scans carry a big dose of radiation. So we don't necessarily want to CT scan everyone. A CT scan of the C-spine, which is what we're talking about doing here, is 100 to 400 times an X-ray of the C-spine. It's 2 to 5 times a CT of the head. This is a big difference, and we need to keep this in mind. So how do we rule these out, or how do we try to figure out who needs it? We use the Nexus rule, and we use the Canadian C-spine rule. These are great clinical decision rules that you should really be familiar with, clearly for your pre-hospital time and also for the CAP. So let's talk about each of these. Nexus was brought forth by Jerry Hoffman's group. It was published in Annals of Emergency Medicine in 1998. It was a prospective study of 21 emergency departments. They excluded all penetrating trauma or direct blows, and the sensitivity was found to be 99%. Of course, we sacrifice specificity for a rule like this. This is 12.9% on specificity, with a negative predictive value excellent at 99.8. Ian Steele's group in JAMA in 2001 set out with a goal to improve the specificity of Nexus. So that was their goal when they started this, and they had the benefit of seeing the Nexus criteria. And in Canada, of course, they had a much easier time kind of collating all their data. So they looked at stable and alert patients who are greater than 16 years old. There's not a lower limit cutoff in Nexus. And they looked at a cross-validation in 10 emergency departments. Their sensitivity, amazingly, 100%, and specificity, 42.5. Great. So again, if you had to choose one just by the numbers, I guess I would choose Canadian C-spine. It gets a little more nuanced, though, when you actually look at how to implement the rule. So Connexus is centered around these kind of 5 things. So no midline tenderness, no focal neurodeficit. They need to have normal alertness, no intoxication, and no painful distracting injury. For the Canadian C-spine rule, it centers around 3 questions. Number 1, do they have a high risk factor that mandates doing some type of imaging? Their high risk factors were greater than 65, a dangerous mechanism, which they equate to falling 1 meter or about 5 stairs, an axial load to the head, a motor vehicle crash greater than 100 kilometers per hour, that's 62 miles per hour for us, and ATV crash, ejection, or a bicycle versus an immovable object. And then finally, paresthesias in the extremities dictate that you have to do some type of imaging. Secondly, if they don't have any of those, do they have a low risk factor, which then allows you to do range of motion testing? So was it a simple rear and MDC? Are they sitting in your emergency department, or are they sitting at the time of the exam? Have they been ambulatory at any time afterwards? Do they have a delayed onset of neck pain, or do they have no midline tenderness? So if you can say yes to those, or any of those, then you can progress on to range of motion testing. And for that, you actually rotate the neck 45 degrees left and right. And this is actually plus minus pain. So that they would tell you there's a bit of a gestalt. So if they have midline pain with that, I would stop. If they have lateral muscular pain with that, the writers of the Canadian C-Spine would likely say that you still do not need to do any imaging. All right, so this is good, but we've already said that Canadian C-Spine took out the people who are under the age of 16. So what about kids? Well, the PCARN group, if you're not familiar with them, the Pediatric Emergency Care Applied Research Network, who's been nice enough to give us an excellent CT head rule for concussion and traumatic brain injury, started to propose a rule in 2011 in the Annals of Emergency Medicine. There, they studied 540 cervical spine injuries. For controls, they had about 1,000 kind of random controls from their data set, about 1,000 mechanism controls, and then about 700 EMS controls. And they focused on 8 high-risk factors. And you recognize these again from previous slides here. So ultramental status, focal neuro, neck pain, torticollis, substantial torso injury, predisposing factors, think JRA, a diving injury, and a high-risk MDC. Their sensitivity was 98%. Specificity in this was 26%. It has never been fully validated and brought forth as a full rule, PCARN rule, as the head CT rule has. But there has been at least one study that tried to compare the 3. So a single center prospective observational study in Australia had some interesting findings. They looked at patients who are under the age of 16 and as a tertiary pediatric emergency department over its time span of 1 year. They had about 1,000 enrolled. 973 had no prior imaging. So those were the 973 that then got enrolled in the study. 40.7% of them had imaging. You can see the breakdown of that. Majority, obviously, x-rays and then CT and then MRI. And 5 of those 973 had a cervical spine injury on imaging. All 3 rules were positive for all 5 of those people. So the problem comes in, though, as the writers say, is that if the rules had been strictly applied, because they were done not so strictly, the clinicians were permitted to use their gestalt on things, that Nexus would have actually ordered imaging on 44%, Canadian C-Spine would have ordered imaging on 48.4%, and PCARN on a whopping 68%. So their conclusion was that the clinical decision rules, while they've been designed to guide imaging, if strictly applied, would likely increase imaging rate. And they make the inference here that maybe they're not all they're cracked up to be, and that you can maybe not do so much imaging as what these are saying. So for this, though, I like to insert what I call fun with stats. So, sorry, I wanted to give you a minute to read the cartoon. So I like to put one of these in each of our lectures with our residents and fellows as much as I can, because I don't want you to be ignorant when it comes to stats. And so try not to fall asleep at this point if you haven't already. But there were 973 people in this study. 5 cervical spine injuries were found. That gives you an incidence of about 0.51%. Compared to the Nexus study, where they, out of their 34,000 total, there were 3,000 that were under the age of 18. Out of those, there were 30 cervical spine injuries, which is about a 0.98%. So you already start to think, okay, is this the same population or not? All 3 CDRs flagged positive. And so the big question is that 100% sensitivity? And at the risk of causing post-traumatic stress disorder, I bring out our 2x2 table. So remember, sensitivity is A divided by A plus C in this chart. So there were 396 that were imaged. The problem is that our imaging rules, our clinical decision rules, all had a higher number that they think should have been imaged. So even PCARN was suggesting that 265 other patients be imaged. And then the question is, out of 265 patients, what's the chances that 1 or 2 may have had another cervical spine injury. Of course, you can't do the gold standard on everyone. Problem being that the imaging issue. Unfortunately, this isn't really talked about in the discussion. And what you really need to have for this study is excellent follow-up. And sometimes it's hard to tell from reading a study exactly how excellent their follow-up is. So just again to point out that when you're reading a study, try to read it critically and try to look into what they're talking about and not just accept their conclusions all the time. All right, so let's move out of that. Now, you can't clear the C-spine. So we're going to do spinal motion restriction. And then the next question is pad removal. I understand that's a Lockman's test. That has nothing to do with pad removal. But I point this out because of this. We're not good at this. Now, we as a physician group, I hope that our sports medicine fellows will become excellent at this if they aren't already. And I hope that us as a subspecialty are excellent at this as well. We know that our emergency physician group is not always great at this. And I'll be the first one to admit that. We do a lot to try to teach our residents to be good at this. But from the NATA, I highlighted the part, and actually I just went ahead and put it into some bullets, is that our athletic trainers are the medical professionals with the most training and experience in this. And the decision to remove equipment before transport should be based on a variety of factors. Training and experience of the on-field group, as well as the emergency room physicians or rescuers, as they refer to them here. So we got to make that decision kind of ahead of time. So I go back to this now, pad removal. I want you to see pad removal like a Lockman's exam. If you're not good at it yet, I want you to be good at it by the end of the year. The Lockman's exam is something that everybody in our subspecialty should be really good at. So let's talk a little bit about pad removal. Biggest thing, number one, is C-spine stabilization. This needs to happen immediately. And you really shouldn't move them from their position until everything is ready to move them. So in our case of the person who was prone, we don't necessarily want to move them until board is there and we're ready to roll them over as a team. You need to hold C-spine from above and below at some point. So that's why I put this picture in. Next then is once the C-spine is stabilized, you need to get the face mask off. And it needs to come off completely. You don't want to leave the face mask kind of stuck up like this because then you create a gigantic lever that will move the head with even a slight amount of force. The next is the jaw pad area, which will cause a pinch on the jaw. So you'll likely want to either remove the jaw pads if you can, or you may need to pull laterally a little bit. The important thing here is that you don't necessarily want to pull laterally too much because it'll start to pinch in the back part of the helmet, which also causes an issue. So the back part of the helmet needs to ride over the occiput as you're pulling it off. For that, you're likely going to need to tip the helmet slightly forward as you slide it off so that that posterior part can then progress past the occiput. Next is cutting stuff off. So there's emergent and then there's non-emergent. In an emergent situation, everything gets cut off and we don't really look back or think twice. In a non-emergent situation, and for some of the schools that I've had some experience covering who don't necessarily have the best funding, our equipment personnel are always quite thankful if we can be a little more careful when we're cutting jerseys off and not cut straight down the middle of a jersey. If you cut down a seam, they can sew that back together. And the kid's not quite so embarrassed when they have to wear a jersey then a few weeks later that may have a giant cut down the middle of it and had to be sewed up together. So just throwing that out there, finer point. Chin straps, jersey comes off, shoulder pad straps, the string that holds the center of the shoulder pads, all of that. Next, we talk about the levitation method. Some people call this an 8-person lift or a 9-person lift or whatever you want to call it. They may have different names for it. I call it levitation. And we need to have our assigned rules. So you have somebody who's doing C-spine from the top, and they're going to be in charge of removing the helmet. You have somebody who's doing C-spine from the bottom. You're going to have one person whose only job is to remove the shoulder pads at the exact time that the person is removing the helmet. And then you have your levitation team. So this is 6+ people. I put the plus in there because it depends on their size. And I frequently heard that you can't do the levitation method with a large football player or any large athlete. I adamantly disagree with that. I have done it. I've done it in practice. We've done it multiple times in practice. So we had a WV lineman walk on last year who likely was the shape of this on the right. So he was about 5'7", he was about 340, which gives him a BMI over 50, which we thought would give us the greatest mechanical disadvantage for our team. I'm not sure how many we ended up using, whether it was 10, 12, but we packed in on each side of him and performed it just as we would with a smaller person. I believe you can do it. So, and I believe there's a reason to do it that way. So, and then you can also add a person to slide the board in from the feet, which is another finer point, so that you don't have to roll them a second time to slide a board under them. So, we did a video several years ago with our residency. This is a URL to be able to find that if you'd like. It's on YouTube. I whittled it down to 5 images here. So number 1 is you have to have the person holding C-spine from the top. Number 2 is everything needs to be cut off so that you can slide this off easily. Number 3, you need the person holding C-spine from below and everybody gets a grip. 4, you lift that person 2 inches. You don't need to lift them more than that. All we need is enough to slide the pads out from under them and slide the board under. That is, does not need to lift this person 12 inches off the ground. And then finally, it's the return to the ground. Pretty easy. When it comes down to it, though, it takes practice. And you have to take charge of the situation. You need clear, short instructions. When I say 3, you're going to lift the patient just 2 inches off the bed or off the ground. You're going to hold him there until I count to 3 again. Simple things like that. And then demonstrate it before you do it. Show them what you mean. Show them how far 2 inches is to lift them off the bed. It's not far. And then finally, the most experienced person should be the person on the helmet. The second most experienced person should be on the C-spine from below. But really, for all the others, this is relatively straightforward. And so I encourage you to practice this with your teams. Possibly go to your local emergency department, wherever. If you had a patient who went down at your football field at the first game in a couple of weeks, and you had to send them to an emergency department, go to them, go to their medical director, talk to them and say you'd like to have, be able to meet with some of them to at least show them this and be able to walk them through this if you're going to be sending them to the emergency department. I put this in here, I likely should have added this as a disclosure at the beginning, but I am not a fan of the torso tilt, as you might have guessed from my last couple slides. My problem with this is you must have a cleared lumbar spine for this. We've already covered from the consensus statement that spinal motion restriction would have to apply to the entire spine. So I'm having a really hard time imagining a scenario where I really want to keep inline stabilization because I'm concerned about a cervical injury, but I've somehow already cleared the lumbar spine. It is described in the literature though. It takes 4 to 5 people. Again, C-spine from the top, removes the helmet, C-spine from the bottom, one person removes the shoulder pads, you have this guy awkwardly standing on the bed and trying to lift this person up. I suspect if this was a large lineman, you'd have the same issue with trying to do that. You'd probably need more people. So don't limit yourself to just a minimal number. So quick release shoulder pads are unfortunately have not really caught on, at least in my experience in our part of the country. Maybe they have in yours, that would be great. They can definitely help make things easier. These have a cord that comes out the center. I believe the brand name is Ripcord. I'm not advocating for them by any means because unfortunately, as I said, the market hasn't really caught on to this since this is a relatively rare thing. And so for a football group to pay the extra money possibly for these shoulder pads, I guess they're not willing to do it. But hopefully it's different in other places. So some pad removal take-home points here. So C-spine from above and below. Make sure to remove that face mask completely. Helmet and shoulder pads should be coming off at the same time. You need to tip and slide the helmet. Remember the multi-person lift or levitation method. There's the torso tilt and those quick release shoulder pads. And finally, you need to practice, practice, practice. So anatomy review. Dr. Laskowski in his lecture did an excellent job with his limited amount of time in dropping lots of helpful nuggets on anatomy. You should have a study plan for this, for the nerve roots. This is something I would suggest you cover at least once a month, whether you're just reading through some type of tutorial or something, or talking through it with your fellowship staff. Also, the spinal cord injury patterns. If you can remember this slide, you can pretty much remember all of those spinal cord injury patterns, the partial spinal cord injury patterns. Of course, those are often tested, and so I wanted to put a slide on here about those. So remember, for central cord, they have an incomplete tetraparesis with upper extremity greater than lower extremity effect. Their sensory deficits, though, are variable. For anterior cord, of course, that's the red area here on the slide in the center picture. They lose pain and strength below the lesion, and but their touch and proprioception are preserved. Of course, then posterior will be the opposite here. They have a loss of sensation, but their strength is preserved. And then finally, Brown-Séquard, which I always find interesting. I believe I've yet to see a Brown-Séquard. I'm sure some have. I think it's rather interesting to think about, though. You have an ipsilateral paralysis and sensory issue below. You have a contralateral loss of pain and temperature. And then my one and only chronic condition. So you can, I know you're all muted and you should stay muted, as Myro told you, but feel free to shout it out if you know who this is. Don't wake up your kids if you have them. I don't want to be blamed for that. If you don't know who that is, I'm going to give you a slight hint here. And if you still don't know, that's Bobby Jones. So Bobby Jones is considered the greatest amateur golfer in U.S. history. He held what was considered the Grand Slam at the time, which was the U.S. Open and the U.S. Amateur, the British Open and the British Amateur, all while maintaining his amateur status, obviously. And he is the one who's credited with starting the Masters. But the question is, what spinal cord issue resulted in his death? And which of the four from the previous slide is it most closely related to? So if you're not aware, Bobby Jones died of complications from syringomyelia. And of course, that's closely related to central cord syndrome. So when we think of central cord and syringomyelia, it is the chronic form of central cord, at least how I think about it. That's likely an oversimplification, but it's a fun trivia question. Next, we're going to talk about fractures. We are going to go relatively quickly through fractures, just to let you know that. But these are, again, things I want you to review. So we know that the shape and the structure of the cervical vertebrae are different than the thoracic and lumbar. So that makes some of their injury patterns slightly different as well. There's a relatively short list of stable fractures and injuries. It's slightly easier to remember this stable list than it is the unstable list. But wedge fractures, clay shoveler's fractures, which are most commonly C7, but can be C6 through T3, a transverse process fracture, a unilateral facet dislocation, a burst of the vertebral body, not always, but many times it is stable, and an isolated fracture of the articular pillar. And a final reminder at the beginning of this part is that if it involves the foramen, so if the fracture involves the foramen, they need a CTA. We need to rule out vertebral artery injury. So atlas fractures. Those are 3 to 13% of all cervical spine fractures, and about 40% of those have an associated axis fracture. The posterior arch is the most common of these fractures. It's stable posterior arch and lateral masses. They typically get treated with just a Philadelphia or Aspen collar. I prefer Aspen, they're more comfortable. And the next fracture being then a Jefferson or burst fracture. For these, the anterior and posterior rings are disrupted. They have 7 to 8 millimeters of lateral mass displacement. For stable burst, Jefferson burst fractures, they get external immobilization. I reference a paper from 2017, and all these are in my references at the end. It was published in World Neurosurgery, where they showed there was no difference between halo device and a hard collar. So I'm sure you'll find some spine specialists who are likely cemented in both of those camps, that either you have to do a halo for these, or the ones that say it really doesn't matter what you do, but at least there is some evidence that you can do either one. For those that are unstable, they will need potential operative fixation. Axis fractures, Those are 18% of all cervical spine fractures, and 60% of those involve the odontoid. So recall that a type 1 odontoid fracture is relatively uncommon. It's about 2 to 3% of these. It's an avulsion fracture. It is stable and just requires external immobilization. Type 2, most common, is the most common one. It's about 60%. It is usually most displaced and unstable, and has a high rate of non-union, somewhere between 30 to 60%. And then type 3 also are stable. A reduction with skeletal traction with a very light weight typically needed, and immobilization with a halo vest, and delayed surgical fixation only for non-union. It's interesting that on a recent shift, I actually had 2 odontoid fractures and a C5 fracture. That's probably because I was giving this lecture, I suppose. Given my shift a couple days ago, I think my next talk will have to be on subcutaneous emphysema with extension to the mediastinum, because I somehow had 2 of those on that shift. So always kind of interesting what you see. Our axis fractures continued here. So Hangman's fracture is an extreme hyperextension injury. It causes a fracture of the bilateral pars interarticularis. Nowadays, given that we don't necessarily hang as many people, unfortunate suicide being then the most likely cause of hanging, that motor vehicle crashes or diving are much more likely. This should be considered unstable and needs external immobilization because non-surgical treatment is what's pursued in about 95% of these. Now, getting below the axis, the subaxial fractures, C5 is the most commonly fractured vertebrae below, cervical vertebrae below the axis, and C5 on C6 is the most common subluxation. Recall that the canal narrows subaxially, which means that the same injury or fracture of the atlas or axis may not have nearly as much cord issue as it does at C5 or 6, just because the canal is much narrower. So, flexion teardrop fracture. This is a severe ligament and disc injury. It's unstable, often with neurologic injury, and reduction and surgical fixation is likely required. The clay shoveler's fracture, be it direct trauma, like with a weightlifter possibly, or a sudden muscular contraction, stable and rare neurologic deficits. A burst fracture, a comminuted vertebral body that shatters outward. It's stable as long as the ligaments are intact, but obviously unstable if the ligaments are not intact. A neurologic injury will depend on the location of the fragments from this. For those that are stable, it's reduction and immobilization. For those that are unstable, or if there's inadequate immobilization, then surgery is required. Now, a subaxial non-fracture, bilateral facet dislocation, which is 50% or more anterior translation of the body. These are extremely unstable, and typically with neurologic injury, it's easy to imagine that, as you see where the spinal cord would have to travel to progress down the C-spine here. So these are associated with vertebral artery injury as well, so you likely would need a CTA of this, and reduction in surgical fixation is needed. So that was a run through some fractures and even that last non-fracture, but I want to point out ligamentous injuries. So we can't forget about these. So remember, these are not going to show up on X-ray and CT. These are why we typically leave people in C-collars if they're still having some symptoms, even if their imaging is negative. This is also why we stay away from acute flex X views in the emergency department, or if you're seeing somebody acutely and ordering imaging, we do not order flex X views on the first imaging that you do. We need to make sure that they don't have a ligamentous injury before we do something like that. The next major topic is cervical cord neuropraxia. Again, a topic that is frequently tested, is a topic that our subspecialties should be well versed in. Some people call it transient quadriplegia. I prefer cervical cord neuropraxia just because, as you can see or will see, that there's a huge variation in the symptoms from this, so they may not have full quadriplegia. Mechanism, it can be either a hyperextension or a hyperflexion, and it has a plus minus on axial load. Fortunately, it is quite rare, 0.2 to 2 out of 100,000 athletes. They may have paresthesia all the way to full numbness. And burning hand syndrome is likely a variant of this, and central cord syndrome. They may have anywhere from mild weakness to full paralysis. So there's a huge spectrum there of symptoms for this. They clearly need spinal precautions in the acute setting. Fortunately, it lasts typically up to 48 hours, but usually less than 15 minutes. We need to be evaluating for both bony injury, typical radiographs or CT scan for that, but also cord injury with an MRI. Sawura and Sawina, so spinal cord injury without radiographic abnormality, meaning X-ray or CT was negative, versus spinal cord injury without neuroimaging abnormality, meaning we didn't see anything on X-ray, CT, or MRI. And these people will then need MRI with diffusion weighted imaging and diffusion tensor imaging. Sawura was a diagnosis that is likely going to become less and less common as our MRI technology gets even better. Because I'm sure in 10 years, there'll be some new MRI technology that can even pick up more of these injuries. So obviously you want to stay abreast of that data. Return to play after this, clearly they must return to normal strength, normal sensation. They must be able to have a normal range of motion. They should have imaging, including FlexX, that at that point is back to normal and shows no abnormality. They must be pain-free. And then finally, we need to hold them out. If there's any of those abnormalities still on imaging, if there's any cord damage, if they've had more than one event of cervical cord neuropraxia, I am not going to be clearing that person. And if somebody else clears that person, I'm going to have a long conversation with them if there's somebody on my team that I'm then going to be covered. They have, if it's been more than 48 hours, then we need to hold them out as well and take a better look at that. And we do believe that our heads-up tackling techniques, as tackling has evolved and rule changes have been implemented, we believe it's at least decreasing some of this and hopefully making a difference. Stingers and burners, and we are getting close to the end, I promise. So stingers and burners, we need to make sure we ruled out other injuries first before we settle onto this, at least thought about other injuries. For motor and sensory injury of the brachial plexus or plexopathy, this can be caused either from traction, as in letter A, direct trauma, as in letter B there, or compression on the opposite side from letter C. Previously, it was thought that it was always a traction injury, but it does not have to be. They should be subjected then to a full neurologic exam of neck, shoulder, complete arm, including elbow, wrist, hand. We need to really be trying to tease out whether they've had some injury of this or whether it's still going on. Because ultimately, there are many that will return to the same game as long as they have a full resolution. So you want to be confident that they have resolved completely. You want them to be able to protect themselves when they return to the field. For those that have recurrent stingers, so 2 stingers in the same game or 3 in the same season, they need additional workup. They need imaging. That would typically start with an X-ray with AP, lateral, FlexX, odontoid views, and then progress on to MRI as well. If they have symptoms that are persisting, then they would likely need an EMG as well. And the return to play from this then is quite an individualized process. As you can imagine, we've got several nerves, nerve roots at least T5 through T1 that can all be affected in this, plus some others possibly. This is something that is going to be very individualized. We do believe it's closely related to spinal stenosis, so this is the reason for some of our imaging. Levitz et al. In the American Journal of Sports Medicine in 1997 looked at radiographs of American football players with recurrent stingers. 53% of those had congenital cervical canal stenosis, and 93% had disc degeneration with narrowing of the intervertebral foramen. Kelly looked at the Torg-Pavlov ratio in a similar group. You knew you couldn't see an acute C-spine injury without the Torg-Pavlov ratio. It had to be touched on. Even though all the other lectures did, I guess, save Dr. Den, I had to still mention it as well. But there is a significantly higher risk of cervical spinal canal and foraminal stenosis. So torque-Pavlov ratio, let's just talk about it quickly. So normal canal diameter should be about 17 millimeters. We know there's a risk at less than 13 millimeters. The normal ratio should be about 1 between A and B, as you see on the picture here. But this creates issues with our large athletes, who of course have typically a much larger vertebrae. The ratio can become less meaningful. And it's been largely replaced by MRI and CT findings. So now we've really settled on to a diagnosis of exclusion, which is the cervical sprain and strain. I put both of those on there. Again, I know there are some purists who like to say, the sprain is a ligamentous injury, the strain is a muscular injury. Some use them interchangeably. So I usually just use them interchangeably and then add that caveat in there so that you recognize that. Our initial management really needs to be rest, early, gentle range of motion, and physical therapy or physical therapy modalities. We really want to resist the urge to stretch it, as with any of these kind of stretching mechanism injuries, whether that be a hamstring, a quad, a bicep, whatever, to continue to stretch that injury, although it is tempting for whatever reason. Many of our patients will tell us, really, doc, I just feel like if I could just stretch this out, it would fix it. Many times what they're actually doing is prolonging their disease process there. So we want to tell them to resist the urge to stretch it significantly. Obviously, we want them doing gentle range of motion exercises, trying to get back to normal activity. They may need some type of follow-up, may or may not for many of these cases. And then a return to play really needs to be kind of progressed and done as tolerated. So this is a segue into our return to play. So, as I constantly do a return to play for this lecture and kind of the different things, and I tried to focus more on an acute setting, and I reviewed Dr. Bales's lecture. I made this URL for you because that'll take you directly to minute 1204 or timestamp 1204 on the YouTube link there. And he does an excellent job of going through a flow chart that notably he and some of his co-researchers developed. And it breaks these down into type 1, 2, and 3 injuries. So type 1 is a transient episode who has negative testing, and the differentiation here is between first-time episodes and multiple episodes. First time, then you can attempt to return to play. If it's a multiple episode, they're out in his view. And I think that's probably pretty smart if they're having a full transient episode, as we talked about with the cervical cord neuropraxia. For type 2, these ones actually have documented spinal or neurologic injury. They are clearly out from contact sports and need to be, really think about very low risk sports, if any, depending on what their injury is. Type 3, they have some other radiographic abnormalities. So they have fractures. For those, we differentiate into they're stable, even with stress. They're stable but without stress. When you stress them, they do show some instability. And then finally, those that are frankly unstable. Those that are stable with stress may be able to do a return to play process. Stable but only physiologically, those are likely out, and obviously the unstable ones are out. And then the other structural things like a ligamentous compromise, herniated disc, congenital fusion, those need an individualized return versus those with ligamentous instability, canal stenosis, or cord contusion, those are out. So I want to finish with something that I consider very practical. So frequently we're faced in the emergency department and sometimes even in the training room with acute C-collar clearance. So for C-collar clearance, they need to have normal mental status, no intoxication, no neurosymptoms. That's easy. That goes without saying. They need to have no midline tenderness, and they need to have a normal range of motion without pain. Finally, they have no neurosymptoms during any of that, during palpation, during range of motion testing. If they do, and there's any doubt, they need to stay in the collar and then be followed up sometime later, whether that's a few days, a week, a couple weeks. That's kind of up to you. And then we have when people come to our clinics and need C-collar clearance. So clearly, we want the same things. We're really focusing again on midline tenderness, lateral tenderness, muscular tenderness, or muscular pain. We're not going to view in the same way. And for these people, this is the time that we are going to possibly use the imaging with the Flex X views to make sure that we don't see any evidence of ligamentous injury. So to run through our cases then, from case number 1, the weightlifter who had the C7 spinous process fracture, that clearly is a clay shoveler's fracture, is what we're alluding to there. And those we know are quite stable. And if his pain is controlled and he has no neurologic symptoms, he can compete. For case number 2, 21-year-old male football player. This injury, of course, is a stinger. The important thing here is that it lasted much longer than his previous ones. And oh, by the way, he had 2 of them already this season. That makes this 3. He needs much more, or he needs more of a workup and imaging before return to play. Remember, the other one is 2 episodes in 1 game. These are not necessary to be done emergently if the symptoms have resolved, but they do need work done. Case number 3 for our jockey, we'll call it horses. While you're not caring for the horses in this scenario, horses run pretty darn fast, 30 to 35 miles per hour. So imagine being thrown out of a car at 30 to 35 miles per hour. This is a high-risk injury. They have, this person needs spinal motion restriction, and they need to be taken to the emergency department. Clearly, you would not be allowing her to ride in her next race. She is at least concussed, if not cervical spine injury. For case number 4, cervical cord neuropraxia, this patient is likely going to need MRI, possibly with diffusion-weighted diffusion tensor imaging. And if her symptoms had continued, she would even need an EMG. Case number 5. So our football player who's laying prone, we alluded to this one earlier. First thing is when you get there is to stabilize him in the position where he is and not roll him until you have all of your people and supplies needed for that. And then finally, of course, when we remove helmet and shoulder pads, we remove those together. So, brief recap then, just a rundown of what we went through. It was a lot. Sorry we went through so much, but hopefully you got something out of it. So for spinal motion restriction, remember, do no harm. We want to make sure that we're doing this right. We use our clinical decision rules for imaging, pad removal. We want that to be like doing a Lockman's for you by the end of the year. Remove that face mask completely, C-spine from above and below. Take charge when you use the levitation method. Remember that those partial spinal injury patterns, those are frequently tested. Also remember that Bobby Jones had syringomyelia. The stable cervical fractures are an important list to remember. Wedge fracture, clay shoveler, transverse process, burst, isolated articular pillar, and the unilateral facet dislocation. Cervical cord neuropraxia, it may be a central cord variant. Advanced imaging with MRI, with diffusion-weighted and diffusion tensor imaging. For stingers and burners, 2 per game or 3 per season needs workup and further imaging. There's an association with spinal stenosis, we believe. Remember that torque Pavlov of less than 0.8, also kind of useless. You don't use it as much, but you could likely use it to help at least rule some things out. If their torque Pavlov is greater than 8, that may be helpful. I think that's how most people are using it these days. C-collar clearance, be systematic, leave them in the collar if there is absolutely any doubt. And what I am most proud of, given our last 2 years, is I didn't mention COVID once in this entire lecture. So I think that deserves a round of applause. And then our bottom line. So of all that, what are the important things? I underlined 4 here. So remember those clinical decision rules for imaging. Those are important. They can help inform whether you're going to do spinal motion restriction on this person. Recall that C-spine from above and below and take charge on the levitation method. Practice, practice, practice. Remember, you may need advanced imaging with MRI, with diffusion-weighted diffusion tensor imaging for cervical cord neuropraxia. And then finally, that stingers and burners, 2 per game or 3 per season. You got to hold them out, give further workup and imaging. That is a list of my references and resources here. And finally, just want to thank you for your attention.
Dr. Monseau, that was a great lecture, and thank you for kind of adding on for what the other presenters have been giving earlier this year in the past. Just a reminder to everybody to please, review those lectures if you'd like to on the AMSSM channel on YouTube. We do have a couple minutes, so I had one question that rolled in initially. This kind of goes into my question too. This is from Pete Cristiano. He said, basically, is there any studies that say which is better in regards to taking helmets and pads off on the field versus waiting until they get to the ED?
Unfortunately, so studies versus good studies, right? So I don't know that we have been able to demonstrate that just yet adequately, I think, to make a full claim on it. Much of what we do is more theoretical, but there are at least some studies showing that, number one, all of our spinal immobilization tactics allow for some movement, unfortunately. But I prefer the levitation method just for, at least conceptually, there shouldn't be as much of an issue given the fact that you have to have a clear lumbar spine for the torso tilt method. So I'm showing my own bias in that, though I fully accept that.
And kind of to kind of also dovetail on that, I know you talked about practicing like removing these with your team. How often and when do you train with like your ATs with the other medical personnel and emergency personnel, for example, at West Virginia?
Yeah, so we typically practice at least a couple times during August camp. There have been other years where we practice even more during the season. I believe there are at least some NFL teams that will practice before every single game. So I think there are some differences there. Just it depends on your level of comfort and possibly how much of your team changes out each time. I think it's important to practice that and be very comfortable with it. I think if I were covering a high school and I don't have a team of athletic trainers or a team of even athletic training students who we can practice this with multiple times, I would practice with my coaching staff. I would practice possibly with some of my players. I'd practice with everybody who's going to be around in case you need to use all hands on deck in an emergency situation, to turn to the coaching staff, who even in high schools, there's usually at least 5 or 6 of them floating around that you can then use to pull this off. I think that's important. Again, if you're going to practice at the emergency department, doing it prior to, yes, even August practices would be good, since football is kind of the big one here, especially when we're talking about taking out of pads. So, but even now, I wouldn't be shy about talking to the medical director of your local emergency department and offering to come in and kind of work through some of these things with some of their both nurses and physicians or mid-levels or whatever.
That was good, thank you. I don't see any further questions. I'll still leave the chat open if anybody has anything else they'd like to ask. But thank you, Andy Meyer. And remember, if you look in that chat function, you'll see the link to the evaluation that you can fill out for this lecture. AJ, that's all I have right now. I don't see anybody else have any questions, but I think you covered a lot of it, so that's probably why everybody's just kind of like, oh, you've answered everything that I wanted, right? And again, reminder, please tune in next week. Again, we'll have Dr. Daphne Scott, who's going to be talking on clearance in sport. So again, if there's no other questions, thank you again, Dr. Monseau. And again, we look forward to utilizing your tips and tricks on the football field or in the fellowship in the year to come. So thank you.
Thank you very much.
All right. Bye, everyone.